Good afternoon and welcome to this breakout session on healthcare reform. I'm Clark Cochran. I'm deacon at St. Peter Catholic Church in Charlotte, North Carolina, the Jesuit church in uptown Charlotte. And I'm delighted to be here with you for this session. The session will be in three parts. The first, what's the goal? The goal is universal health coverage, and we'll talk a little bit about what that means. What are the obstacles to this goal in the current political and social environment? And what policies are actually on the agenda for the next year or two or three that might help to reach that goal and to overcome the obstacles? So first, what's at stake in healthcare reform? The dream of universal healthcare is at stake. Healthcare is a fundamental right of all human persons. It's not a privilege to be earned. Healthcare is the basis of flourishing in a human community as a person or as a community. It's a right as fundamental as food, clothing, safety, and shelter. And it's the right for all persons. A right in the United States for all persons, whether they are citizens or not citizens, whether they are documented or undocumented. Rights always entail responsibilities, and to say that healthcare is a universal right is also to say that we have a responsibility, both personally, to take care of our health and maintain it, and socially, to take care of each other and our health when we need that care. So it's a right based in Catholic social teaching. Pope St. John the 23rd in Pacem in Terris, his encyclical 1963, affirmed the right to health care. And every pope since then, in the last 60 years, has reaffirmed that the basic fundamental rights of each human person include the right to health care. The United States Conference of Catholic Bishops, as early as their 1981 pastoral letter on health and healthcare, affirmed that government working on behalf of the common good has an essential role to play in guaranteeing the right to healthcare of all persons. And the Catholic Health Association of the United States, the association of all Catholic hospitals, clinics, medical practices, long-term care facilities, has affirmed that right for the last 50 to 60 years. Why have all these Catholic leaders affirmed the right to health care? Because it's based in our fundamental Catholic teaching. The principle of human life and dignity. Basic to a decent life personally and communally is health and the care necessary to improve one's health and maintain one's health. The fundamental commitment in Catholic teaching to solidarity and community. We are social beings. We are made for each other. We are saved together. We are therefore our sisters and brothers' keepers when it comes to healthcare and many other things as well. The commitment to justice and government's responsibility to ensure justice. And in this case, it means that each person has a claim on the resources necessary for human flourishing in one's own community. And the option for the poor and the vulnerable, we have an obligation to lift up those unable to support themselves. It's not just Catholics who have affirmed the universal right to health care, however. All Americans, or most Americans, for many, many years have believe that their government has a major responsibility for ensuring that all Americans have healthcare coverage. And this is basically 60% over 20 years. And if you go, it even goes back farther. I don't have it on the graph, but it goes back farther to the 1980s. About 60% affirm that government has the responsibility to ensure healthcare for all. The only exception is the highly intense political debates surrounding Obamacare from 2010 to 2014, where things got really messy. But then after 2014 and the full implementation of Obamacare, things return to normal with 60% or more of Americans believing that government has this responsibility. If we believe this, why don't we have it? And the reason is there are some fundamental obstacles to healthcare reform in the United States. The mythology of healthcare and the culture of American medicine is one. Systematic inequality and political dysfunction is another. And the cost of healthcare reform is a third. And I'm going to take these up in order. So first, the mythology and culture of American medicine. There are a couple of myths about American medicine that get in the way of change. One myth is that Americans already have health care. Now, there is some truth to that, in that 90% of Americans have some kind of health insurance, but it doesn't always guarantee access to care. The myth also says that, well, those 10% who don't have health insurance can get care when they need it in emergency departments or by contributions of care by doctors and clinics and other entities giving charity care. The problem with this myth is that it is in fact a myth, and that even if it were true, 10% of all Americans account means 30+ million persons lacking good access to healthcare when they need it. But moreover, depending on emergency departments and charity care means that a dependence on care that's really not adequate to maintain health or to take care of chronic conditions. Emergency departments are in fact for emergencies, not for ordinary care. And charity care is often hard to come by. And this whole perspective fails to recognize that there is a right to health care, and thus creates healthcare beggars among Americans who don't have good health insurance. A second myth is that we have the best system in the world. It's sometimes argued that despite gaps in coverage, the United States has the best medical condition in the world, and that reform would damage that system and weaken access for hardworking American citizens. However, the problem with this is we don't really have the best system in the world. We have one that's far too expensive. It's by far the most costly system in the world, 2 times as much as most other healthcare systems in wealthy nations. And all that money buys substantial quality problems. Some conditions don't get treated or don't get treated very well compared to the way they're treated in other countries. And on basic health measures of health maintenance and daily quality of care, preventive care, we don't do as well as many other countries, and we live shorter lives, substantially shorter than all other wealthy developed nations in the world. A third problem as part of this mythology and culture is the culture of American medicine itself. Two factors. The first is economic individualism. Our medical system is founded and grounded on economic individualism, which creates a for-profit a profit-motivated medicine. And profit-motivated medicine leads to fragmented and disjointed systems where people look for different opportunities to do well financially in the healthcare system, rather than building a system that takes care of everyone with good quality care. And it leaves huge gaps in quality and huge gaps in coverage. Economic individualism suffers from the problem that Pope Francis focused on in his most recent encyclical, just released a couple of weeks ago, what he called radical individualism, which is contrary to the Catholic commitment to solidarity, community, and the common good. And the problems of economic individualism and radical individualism in the healthcare field have been very well uncovered and revealed by COVID-19. When you have a pandemic, you would think that everybody's in it together, everybody is pulling together, everybody is working towards the same goal. But in fact, as Pope Francis and others have pointed out, we're not all in this together. We may all be in the same pandemic storm, but the boats we're riding in are very, very, very different. Each boat is on its own, and some of the boats are very well furnished and very large and very seaworthy, and others are not so large and not so seaworthy, and some only have life jackets. That's the function of a disjointed system, or the result of a disjointed system. A second feature of the culture of American medicine is that it creates unreasonable expectations both among medical practitioners and among ordinary citizens that everything can be cured, everything can be taken care of, that there can be indefinite progress if we just invest and just use the highest technology, the most intensive, the most high-powered drugs and surgeries and other treatments to take care of our ailments. But this leads to, again, very costly medicine, huge disappointments, and a fragmented system. That's one obstacle, this whole mythology and culture of medicine. The second obstacle is systematic inequality and political dysfunction. And systematic inequality is systemic racism and economic inequality, again, revealed by COVID-19. As I mentioned, that people who suffer from COVID-19, both in terms of health and in terms of death, are disproportionately African Americans, Hispanic Americans, Native Americans, low-wage workers, frontline workers who have lost their health insurance or lost their health or their lives to the pandemic. But even before the pandemic, the pandemic just reveals the problems. There are systematic problems with the impact on women. So for example, the richest 20% of women in the United States over the last 40 years have increased their life expectancy by 6 years. The richest 20% of women 40 years live now 6 years longer than they did 40 years ago. Every other woman in the United States has no change in life expectancy. Black persons have a 3.5 years less life expectancy than white persons. Disparities by race and income also affect access to general care, access to specialty and surgical care, screening rates, timely diagnosis, treatment of any diseases, and care for chronic diseases. So the racism and inequality basically creates a barrier to reform, because those at the top, those who have good care, are afraid to lose it or to change it because any changes might impinge on the economically rich and the socially privileged. The second dysfunction, thing here is the dysfunction of our political and social systems, partisan gridlock, and a growing distrust of all institutions, which obviously interfere with the possibility of reform. And then the third and final obstacle that I want to talk about to healthcare reform is the high cost of reform. As I've suggested, the US has the most expensive healthcare system in the world, twice as much as the closest rich nations, more than that of other wealthy nations. In 2018, we spent $3.6 trillion on healthcare, $11,000 for every man, woman, and child in the United States. Nearly 20% of our whole economy, 17.7% of gross domestic product, or the measure of the entire economy, was spent in healthcare. And what this means is that any reform is going to be adding just to that, is going to add to that amount of money and increase the share of healthcare in the economy, crowding out other needed spending on infrastructure, shelter, and education, and many, many, many other things. Because we would either have to increase public spending, raising taxes, or reduce the income, the expenditures going into the medical field, thereby affecting the incomes of 20% of the entire economy, or do some of each, both of which would be very painful and very difficult. So 3 obstacles to healthcare reform: And now I want to talk about the actual alternatives that are on the table for healthcare reform in the next year, 2 or 3. First is retain and repair the Affordable Care Act, the ACA, legislated in 2010. It's also known as Obamacare. The second option is to repeal and replace the Affordable Care Act. The third option is to create Medicare for all, also known as single payer. My goal here is just to sketch these options, and I'll conclude with some thoughts about what the best option is from the perspective of Catholic social teaching, in my particular opinion. I want us to remember a couple of things about American healthcare as we get to these 3 options. One is that the private sector provides most of the healthcare in the United States. Most hospitals, physician practices, long-term care facilities, clinics, pharmaceutical companies, drugstores, all of these kinds of things are privately owned businesses, either in the for-profit sector or in the not-for-profit sector, where funds have to be reinvested back into that sector or into the community, but they're privately owned and operated. Most Americans who have insurance receive their access from private insurance policies offered by employers and through insurance companies like Blue Cross Blue Shield or United or Aetna or Humana. Or they are private policies purchased on the individual market by people who don't have employer offered insurance, and they're offered by the same insurance companies that I just mentioned. Another huge chunk of people who are insured receive insurance through public systems like Medicare, operated by the federal government and sometimes administered by private insurance companies, by Medicare, which is operated by the states with the support of the federal government, or by the Veterans Administration, and then a few other federal programs in addition to those. But many Americans, non-elderly Americans, remain uninsured. Most elderly Americans, that is people who are 65 and older, have health insurance through Medicare or Medicaid. But there are many non-elderly, people younger than 65, who don't have health insurance. And this is the chart going from 2008 to 2018. You can see that up until 2013, somewhere usually around 44 to 47 million persons under age 65 did not have health insurance. The green line is the percentage of persons under 65 who don't have health insurance, and it's around 17 to 18% before 2013. And then in 2014 to 2018, it drops substantially, and that's the effect of the Affordable Care Act, expanding Medicaid and expanding private insurance markets and the mandate to purchase health insurance, declining to 27 million persons and about 10% of non-elderly adults. That's the context for looking at these 3 options. So option number 1 is retain and repair the Affordable Care Act. The Affordable Care Act, as we just saw in the previous slide, is very successful in extending insurance, but it doesn't have in it a right to health care. And in fact, 10% of non-elderly Americans don't have health care. And that number is actually growing in the last 3 or 4 years. It's now probably this year will reach about 31 million persons, or probably 11 to 12% of non-elderly Americans. Only 39 of the 50 states plus the District of Columbia have expanded Medicaid. Most of the uninsured are in states that have not expanded Medicaid. And many of the health insurance policies offered under the Affordable Care Act or by employers have become unaffordable for people to pay the premiums, or even if they have the insurance, they can't afford the deductibles and the co-pays that have to be paid as the employees or the insured person's part of that, of a physician bill or hospital bill. So the Affordable Care Act, as good as it is, has significant gaps and problems. So what would it mean to retain and repair it? One, expand marketplace subsidies, expand the federal government funding subsidies so that more people could afford to buy the private individual policies on the ACA marketplaces. Cap the premiums, copays, and deductibles that any individual or family would have to pay so that no person, no family would pay more than a certain percentage of their income for health care. All health care they needed above that cap, maybe 7% of income, 8%, 10%, would be paid for by the federal government. Add a public option insurance product for persons who have limited options on the individual market or limited options from employers, or who live in states which have not expanded Medicare. A new federal public insurance program would be offered to them so that they could get good, affordable health insurance. We could require states to expand Medicaid, removing the option for states to do it. We could open Medicare to persons under age 65, creating more options for people to obtain insurance as they get older. And we could add undocumented persons to ACA coverage. If we did most or all of these, we would achieve universal health insurance. So that's option one for getting to universal care, is to retain and repair the Affordable Care Act. The second option is to go in the different direction totally, and that is to repeal and replace the Affordable Care Act. Now, this option does not recognize a right to health care. It recognizes that healthcare is something people should have. It recognizes it's something that people want. It recognizes that it's something that people need, but it is not something that every person has a right to. Instead, this perspective argues that the free market in healthcare, market-based healthcare, through competition and through the individual responsibility to take care of oneself, to be well, to avoid behaviors that damage oneself, the individual responsibility to do these things and to purchase insurance would make insurance less costly, more affordable, reduce regulation on insurers and reduce regulation on practitioners like doctors and nurses and other providers, would make less regulation, less costly, and eliminating the tax support to employer-based insurance would again allow people to make higher wages instead of putting all that into insurer-based premiums. All of this together would reduce the cost of healthcare and improve its quality such that more people could afford it and move in the direction of universal coverage. To do this, they would therefore, those who support this position would repeal all of the Affordable Care Act, but then add back some features of the Affordable Care Act which are popular and necessary. They would probably add back cost and quality initiatives in Medicare, add back the requirement that insurance products cover pre-existing conditions. They would retain Medicare as originally developed, not as expanded by the Affordable Care Act, but they would limit federal spending on Medicaid and would impose work requirements on Medicaid. So that's alternative two, repeal and replace the Affordable Care Act. Option three is Medicare for all, sometimes called single payer. And this would either immediately or over some stretch of time eliminate all or most public and private insurance, all employer-based insurance, all individual market insurance, all Medicaid and Medicare, maybe retain the VA, maybe retain military insurance, but eliminate all or most insurance as it currently exists. And also, along with that, eliminate all payments for insurance that we make through premiums, deductibles, co-payments, and many administrative expenses that are paid for this complex system of healthcare that we've evolved in the United States. In place of that, all persons would be enrolled in a new public program, sometimes called Medicare for All, but it could be called anything. A new public program that would cover all medically necessary services, including vision and dental services. Excuse me. And it would be financed by progressive federal taxes on income, personal income, or corporate taxes, particularly taxes on the wealthy and on corporations. So none of us would pay directly for care, whether through our employer or individually at the point of service. At the point of service, medical care would be free. It would be all paid for in the back end through these taxes. Delivery of health care would remain largely private. That is, private hospitals, private physician practices, as I described earlier. The delivery of health care in the United States is primarily privately delivered, and that would remain true under most versions of Medicare for All. So, 3 alternatives, some final considerations about those 3 alternatives. One is that there is no Catholic social teaching that says this is the alternative Catholics must accept. Catholic social teaching does not describe particular forms of legislation that address particular social, economic, political problems. It gives basic fundamental principles. So what Catholic social teaching does is say, look at those principles that we've talked about, the right to health care, solidarity, life and dignity, care for the vulnerable, and apply those principles through conscience and prudence. Add to those principles your own experience, your own reason, the reason of scientists and economists and other people who studied the issue, and then select an alternative which is informed by reason, experience, and principle. It's informed choice that we make as individuals or as groups, but they're always debatable because they're in the realm of prudence. There is no perfect solution. There is no single solution. There are only solutions that we think, based on all of these things, are the best solution for our situation. What do I think? Running this through the principles and reason and experience, I think retain and repair the ACA is the most reasonable way to go in the near future. Why? Well, because it moves towards universal health care for all reasonably quickly. It is best positioned to overcome the obstacles, the political, the social, and other obstacles that we've described. And it imposes the sacrifices, financial sacrifices and other sacrifices on those who are best able to bear them. That is, the currently economically well-off and socially privileged. But these are open to question. And so in the comment and question time that we have following this presentation, I invite you to address questions, comments, challenges, differences of your own analysis on these, and we will try to discuss them in the time available in that session. So again, thank you very much for your time, for your attention. I look forward to our interaction in just a few minutes.